And if everyone can hear me, I'm going to show my screen, and if you could just let me know that you can also see my screen. And as we're going through, if anyone has any questions, please feel free to send them in the chat box, or if it's something when the time comes, if you just want to interject, I'll unmute everyone or send me an email or give me a call when we're finished. So again, we're going to be reviewing Standard 2 of 6 for the PCMH recognition process. The first slide, again, is just an overview, one to provide this every time, just so you get that glimpse of all 6 standards and the various lettered elements that fall within each standard. Again, noting today that we're doing the second standard, team-based care, and recognizing the different scoring levels and the points needed for each level, and the elements within each standard that are most critical, most important, the must-pass elements, which are the asterisk elements within each standard. So Standard 2 has 4 elements. When we did Standard 1, that one only had 3. So this has a little bit more information and a little bit lengthier of factors within some of the elements. So a little bit more of information to get through. But looking at team-based care, the intent of the standard is really looking at the practice providing continuity of care and using cultural and linguistic appropriate team-based approaches. So this really is centering around everyone has a responsibility for some aspect of the patient care. Leadership from the physician or physicians in the practice is essential and extremely important, but recognizing that everyone in the office has to do with some aspect of the patient care, and using the staff to the full extent of their license and of their training. So you can see the 4 different elements: continuity, medical home responsibilities, culturally and linguistically appropriate services, and the practice team. The practice team, you'll see, is the must-pass element, so that one is probably the one you're more familiar with because it's on the separate sheet that I've been discussing with all the offices with those 6 must-pass elements. And when they're talking about a team, they're talking about the primary clinician and the associated clinical and support staff. So again, it's encompassing everyone for this team-based care. Everyone has a role. For meaningful use, throughout all of Standard 2, none of these factors are aligned with any meaningful use measures. So looking at the first element here, 2A, continuity. The practice provides continuity of care for patients and families by the various factors. Number 1, assisting patients and families to select a personal clinician and documenting the selection in the practice records. So I'm pretty sure all offices have the physician recorded in the patient record, but this is just that you give the patients information on how important it is of having a personal physician, having someone that is the center of their care. And discussing this with the patient is also a good opportunity and good time for you to explain or introduce what a medical home is and kind of why you're telling them this information and having this central unit for their care. Second factor, monitoring the percentage of patient visits with selected clinician or team. So what NCQA is looking for here is not only do you inform the patients about having a personal clinician and document it in their record, but then looking to see how often when they come into the office that they're actually seeing the clinician that they prefer. There's no threshold set. There's no certain percent of which these visits have to occur. And again, this includes your regular face-to-face visits. It includes those alternative encounters, so anything scheduled phone visits. And again, the practice defines the rate of continuity. So there's no threshold saying that 75% of the time a patient has to see their desired preferred clinician, but it's just looking to see that you are monitoring how often that occurs. The third factor, having a process to orient new patients to the practice. That's pretty straightforward, but they're looking that you provide information on the medical home model, the expectations and the responsibilities of a medical home. So that's where the new piece comes in. Obviously, you have information that you give your new patients. This is just incorporating information and educating them about medical home and what responsibilities they have and you have. And the fourth factor, collaborating with a patient and family to develop a written care plan for transitioning from pediatric care to adult care. And then you'll see the separate bullets listed for what they're looking for from each type of practice. So the information that the pediatric practice would need to look at, internal medicine and family medicine. So I won't read those to you, but they're there for you if you have any questions. Just let me know if there's anything that's unclear about what to provide as far as transitioning for the care plans for different offices. Looking at the scoring and documentation, 3 points are possible for this element, and you can see there 3 factors out of the 4 would give you the 100%. There's no scoring option to get you 75%. It just goes from 50 to 100. And the documentation requirements itself. For factor 1, the documented process for patients and families, selection of a personal clinician, and then an example, which I have some examples for you to show you. It's pretty straightforward again. For factor 2, a report with at least 5 days of data showing the total percentage of patient encounters that occurred with the personal clinician. There is a report that can pull that. And just wanted to note that it pulls from the provider field in the patient chart, which I'll show you on the example that I have. So making sure that that information is documented there, because that's where the report pulls from. Factor 3, a documented process for orienting patients to the practice. So again, just looking at how you go about doing that, and the 3 different types of practices and what is required of them for these materials and information for transitioning care. I just also wanted to note that for factors 1 and 2, solo practitioners, when they are reporting this, they would simply be able to choose yes, that they meet this, and that simply indicate that they are the only clinician available. So obviously if they're the only one, that's the only option. And if a physician and a nurse practitioner, a PA, if they share panels of patients, then they are considered a team and basically one entity. So looking at the example that I'll show you here, I'll go to the next screen. Skip the slide to show you this documentation information, but I'll go back to the other example. So on the left, you'll see the report that you could run with the patient information always de-identified, and listed is the patient's personal clinician in the doctor column, and then the next column, it lists the clinician that the patient saw for that appointment. So if you're looking at the top bar there, if Dr. Mohan is selected as the patient's personal clinician, and the nurse that saw the patient only sees the other provider's patients, doesn't have their own panel of patients, then that would be considered seeing their personal clinician. They work as a team. That nurse doesn't have her own separate panel of patients. And again, on the right is just showing where that documentation is pulling from for that report. It's in the provider option. And then going back to the other examples, these are examples for the process, for the documented process. Again, most of you received this information in the packets, the templates that I distributed, but this is just clearly showing for the first factor, having that process that you encourage them to choose their personal clinician and talk to them about that, and then that you are monitoring at whatever time frame, whatever rate you set as far as looking to see how often they do meet with that clinician. Moving on to element B, medical home responsibilities. This obviously is new information to provide to your patients and to your staff. But this is looking at the practice has a process for informing patients about the role of the medical home and gives patients materials that contain the following information. So for the first factor, the practice is responsible for coordinating patient care across multiple settings. So this includes specialists, hospitals, rehab facilities, behavioral health. So they are looking that you have information about these different specialists and places that you're referring to and that you help coordinate that. Factor 2, instructions for obtaining care and clinical advice during office hours and when the office is closed. So you provide what your office hours are, where to seek after-hours care, how to communicate with the personal clinician and the care team during and after hours. So that aligns with one of the factors that we talked about with the first standard with providing advice by phone and electronic means during and after hours. So this is just instructions for, again, obtaining care when the office is open and when the office is closed. Third factor, the practice functions most effectively as a medical home if patients provide a complete medical history and information about care obtained outside the practice. This is informing the patient that it will benefit them if the practice has all of this relevant information. So any medications, any specialist visits since you've last seen them that you might not be aware of, any self-care information, ER visits, letting them know that all of this information is essential for you to be able to provide them the best care and keep informed. Factor 4, the care team provides access to evidence-based care, patient education, and self-management support. This is looking at educational resources, different current literature, just that you provide them this information, this education. Number 5, the scope of services available within the practice, including how behavioral health needs are addressed. So this is where we get into a lot of the behavioral health and whole person care. So you're informing the patient on how behavioral health needs are met. It was brought to my attention by a few offices that a lot of times this is not something that the office can basically directly refer to, and it depends on the patient's insurance. If that is the case, simply stating that in the process that you discuss with them that it is through their insurance, by their insurance, and help them to navigate where they have to contact to get that information. Factor 6, the practice provides equal access to all of their patients regardless of source of payment. So this is, if you consider Medicare, Medicaid, the uninsured, again, not necessary that you accept all of those forms of payments, but the access to patients regardless. Factor 7, the practice gives uninsured patients information about obtaining coverage. This providing them any brochures, point of contact information, state Medicaid information, CHIP coverage. So I provided the link there because of the Affordable Care Act. You know, this information most people have, or it's something that you can easily share with them, which is all they're looking for, that you give this information. Factor 8, instructions on transferring records to the practice, including a point of contact. So just helping them transfer their records from a previous practice and assisting with that in any way that you can. The scoring and documentation, you can see 2.5 points possible. Again, 7 to 8 factors being at 100%. And for the documentation, all of the factors require a documented process for giving the patients that information and materials about the role of a medical home. This documentation requirement is a little broad. It doesn't say specifically what you need for each factor, if one of these materials is necessary for each factor. I have a question into NCQA with a few different things regarding to all of Standard 2, and this being one of them. So if anyone has any questions about that, I will be providing some information when I get a little bit more feedback from them about what is necessary with these materials. But just looking at this, patient materials, your patient brochure, web materials, the agreement about the roles of the medical home, and a sample record transfer request form. So on this page of examples, on the left-hand side, you'll see a sample brochure, a lot of information about the background of what a medical home is, the advantages to it, the medical home team, everyone that entails, and kind of their responsibilities. The patient's responsibilities are in that blue box. So that's just a sample brochure giving a lot of that information that they require. And on the right-hand side, I just picked out a few pieces from some of the different templates for these policies, and you can see there they're labeled with which factor they correspond to. So on the top right, about transferring medical records, the middle box looking at information to obtain health coverage and equal access to patients by the office. And in the bottom right, looking at coordinating care and evidence-based care and self-management and how the office goes about addressing those. And again, just to reiterate the fact that these examples, these templates are just there for guides for you to give you some ideas, show you some of the things that they're looking for. But again, a lot of these does not require you to have every piece of information in these policies, just a guide for you to look through and tailor to what your office provides. Moving on to the third element, element C, culturally and linguistically appropriate services. This is looking at the practice to engage in activities to understand and meet the cultural and linguistic needs of its patients by the following factors. The first being assessing the diversity of the population. So looking at race, ethnicity, gender, different disabilities for your population of patients. Factor 2, assessing the language needs of the population, pretty straightforward. Factor 3, providing interpretation or bilingual services to meet the language needs of its population. So this looks at having the services available, whether it be a contracting service for translation, or if you have bilingual staff in your office, simply asking one of the patient's friends or family members to interpret, or someone that comes to their appointments with them does not meet the factor. And the difference between factors 3 and 4 is 4, you're able to respond with NA, but 3, they are looking that you receive credit for this factor if the services are available through, again, multilingual staff or contractors without regard to the level of need for your population. So if you would not have those types of services available regardless of the need in your practice population, you would lose a half of a point. So for this whole element, if you did 1, 2, and 4, you would receive 2 points instead of 2.5. Looking at factor 4, providing printed materials in the language of its population. So this identifies languages spoken by at least 5% of the patient population and makes materials available in those languages. So again, you could respond with NA if the practice provides documentation that no language other than English is spoken by 5% or more of the patient population. Looking at the scoring, 2 points possible, all 4 factors being 100%, and the documentation requirements, looking at a report of your assessment of diversity and language, documentation showing the services available or a policy that the practice uses bilingual staff, and materials in languages other than English, a screenshot showing system capabilities or a link to online materials or a website in languages other than English. And again, that is only if more than 5% of your patient population speaks a first language other than English. So looking at the examples, this is an example of a report run in MedEnt that looks at the language, race, and ethnicity breakdown by offices. So looking at this report, we're then able to look at the percentage breakdown. And you can see by this office, none of the languages other than English even come close to having more than 5% of their patients. So this is where that NA option would be adequate and the materials would not have to be shown as examples. And again, this is a report that's available in MedEnt. You can see on the left-hand side I have where the label is at the top is how that they are laid out, so you can see exactly what element you're looking at and running the report for. Moving on to the last element, element 2D, looks at the practice team. So again, this is the must-pass element within this standard. The practice uses a team to provide a range of patient care services by the following factors. Defining roles for clinical and non-clinical team members. This is just brief job descriptions, nothing extensive, nothing very detailed. Factor 2, identifying the team structure and the staff who lead and sustain team-based care. So something to keep in mind that there could obviously be members within your office who are shared between teams and on different teams depending on what their function. So they're looking at who is trained and responsible, for example, for care coordination, who is trained and responsible for managing the population health, your patient population. So looking at those different team-based operations. Factor 3, which is the critical factor, holding scheduled patient care team meetings or a structured communication process focused on individual patient care. So this would be your team huddles if it's something that you're doing. They don't always need to occur at the same time, but it needs to be on a consistent basis and needs to address patients' clinical needs. So this is looking at individual patients that are coming into the office. So this could be every day. At the end of the day, you look at the schedule for the next day and go through any of the patients that might have issues or something at check-in that could be more efficient, something before the physician sees the patient that could make that flow a little bit better. This could be done in the morning, every morning before the first patient comes in, and again, looking at the schedule for that day. But the main thing is that this is looking at patient care and the individual patients that are coming in for scheduled appointments. For where it says structured communication processes, this could include regular email exchanges, different tasks or messages about a patient in the medical record. So this is where that continuation of information exchange throughout the day that the offices and the whole staff and physicians have about patients that are coming in. You know, that's obviously something, as long as it's structured and focused on the individual patient care, that is adequate. Factor 4, using standing orders for services. So any testing protocols, vaccinations, routine prevention services, anything that either the clinician pre-approved or without approval as permitted by state law, depending on the different team members' license, having these standing orders documented. Factor 5, training and assigning members of the care team to coordinate care for individual patients. So they're looking at how are these staff members trained to provide this type of care. So for 5 through 7, that's the meaning behind these. Who are you training within the office and how? 6, looking at the self-management piece of care for the patient, and 7, looking at managing the patient population. Number 8, holding scheduled team meetings to address practice functioning. So this is different than Factor 3 because this is addressing operational things within the office, different functionalities within the office, clinical and non-clinical staff included within this. So these might be your monthly or quarterly office meetings, staff meetings, addressing practice function. So this is a little bit broader. Things within this meeting look to increase the care provided for all patients in your whole office, whereas Factor 3 is looking at individual patient care and strictly the clinical side of the office. Factor 9, involving care team staff in the practice's performance evaluation and quality improvement activities. For example, discussing outcomes of your patient surveys, quality information from different insurers, any measures that you share with the staff at meetings, looking ahead when we get to Standard 6 with all of the quality improvement and clinical outcomes. This links with that standard in that, sharing different performance goals and outcomes with the whole practice staff. So this is involving all of the care team in this process. And Factor 10, involving patients, families, and quality improvement activities are on the practice's advisory council. So this is just how you would go about choosing patients to be part of different activities or getting their feedback or whatever process you have for involving your patients in your performance and quality activities. The scoring, since again this is a must-pass element, 50% score is needed to pass this element, and without reaching this 50%, the recognition in general is not able to be obtained. So looking at 5 to 7 factors, including number 3, which was your huddle, your daily meetings about clinical care, that is your critical factor, so that's essential for receiving scoring. But that is the threshold that you need to reach, the 50% for this element. Documentation, you can see for several of the factors, dated descriptions of staff positions, policies, describing their roles. And again, the practice may provide a chart or description of the team structure and members to view this, and it's one of the examples that we could take a look at as far as structuring those roles. Factor 2, an overview of the staffing structure for team-based care. Factor 3, which is your clinical factor and your huddle or meetings, So they're looking for the documented process for the structured communication, which states the frequency of communication and reviews at least 3 samples of meeting summaries, checklists, appointment notes. So that's what a lot of people have asked about, how you capture, document, provide evidence that you do have these daily meetings or that you do review the schedules. So this could be a very brief meeting minutes, any checklists, noting in a patient's record something specific that you discussed in the morning as far as when they come into the office, you know, a note saying per morning huddle, ask patient to, you know, fill out a form that they had forgot, or schedule an appointment that is upcoming that they're going to need some type of documentation to show that that's where it came from. Factor 4, at least one example of written standing orders. For factors 5 through 7, the description of training and the training schedule or materials of how staff are trained in each identified factor. Factor 8, looking at the team meetings, and one example of the meeting minutes, agendas. Again, those are your less frequent meetings and your whole office operational meetings. Factor 9, documented process for quality improvement. And factor 10, documented process for involving patients in your practice's quality improvement or advisory councils. Looking at some of the examples, again, these are some of the charts and templates that I had provided, and you can see that the one on the left has some information for several of the factors, so you can adjust the different, if you have different terminology, but again, they're looking that for care coordination, self-management, population management, that who in the office is responsible for those different items and how they go about training and knowing what to do to handle those management operations. On the right, the team care operations, this is looking at the roles and the responsibilities. So you'll see there the assignment on the right-hand side is, you know, who is responsible for that and their role as far as their care team. So the care team leader, for example, being the head physician in the office and what their responsibilities are. On this slide, on the left-hand side, is chronic care standing orders. So some examples of different standing orders, diabetes, hypertension, asthma. Again, you'll see at the top noted that who is authorized through the standing order to perform the following measures. Looking at the right is an example of the team huddle worksheet. Again, can be adapted and adjusted to how you want to address it, how you want to look at your schedule, when you want to look at it. Looking if you want to review yesterday, again, that's not a requirement, but this is just giving you all of those options. Looking if you do it in the morning for your planning for today, are there staff that are not present that day and how you're going to adjust the schedule according to that. Any patients who will need more time, less time, different things like that, so that everyone is aware of who's coming in and what is going to be needed throughout the day for these different patients. Okay, so went through all 4 of those elements. Does anyone have any questions about specific factors or requirements, any of the examples that I showed? Okay, if we don't have any questions, looking at the next slide, just some information An article that I came across that I thought was really helpful specifically for team-based care, all about the standard that we just discussed. So if you want to take a look at that article, it kind of describes the methods behind team-based care, a lot of the associated outcomes with it, and how that team functions together. The next webinar is going to be discussing Standard 3, and again, it will be in 2 weeks. It will be on Wednesday and Friday instead of Thursday and Friday, just for that one because I'm out of the office on Thursday. But that will be the next one, and again, looking at Standard 3. The link is there for the previous webinar that we discussed, Standard 1, and the link for this webinar will also be made available probably later today or tomorrow, and again, having some other offices get on tomorrow morning to discuss the information. Looking at, on the last webinar, I provided information, I believe, about the Board of Family Medicine and the information regarding their certification and how being PCMH recognized gets them points towards that. And it was just added that this is now available for the Board of Pediatrics as well. So some information to share with some of the doctors. I'll be obviously sending this to them as well. But receiving credit, and this is as long as it's accredited only through NCQA for PCMH. And the last thing is some offices, as I was going through things and showing examples, have been asking how you're able to do screenshots of information. So all of the examples that I showed today from Medent, how you're able to take screenshots of that information and show that on your screen as your evidence, your documentation. So this is something that you wanted to ever send to me to get clarification if this looks right, or when the time comes when I'm submitting information for all the offices, this is how I'll be gathering a lot of information. So I just wanted to show you there how that is able to be done. It's the print screen option, which is the button to the right of the F12 button on your keyboard. So nothing will happen when you hit that button, but if you then pull up an open Word document and just click paste, your screen will then come in there in a picture, and you're able to crop and edit that photo, that screen, and will most of the time, maybe it's just my printer that doesn't all the time, but we'll print a hard copy then of your screen as well. So it's nice also because you're getting that documentation electronically that we need to send, and also a hard copy to keep for our records. So I just wanted to share that because a few people have recently asked. So now going through that, does anyone have any questions, anything that they want to add, any suggestions? Okay, well, if we don't have any questions, that will be all. And again, I thank you for taking the time to get on and listen. And if you have any questions, please don't hesitate to call or email me.